Well, good morning, everyone. We have a very special guest. You have heard from Dr. Charles Stewart before. Welcome to the show, Dr. Stewart.
Good morning.
Dr. Stewart's very special. I mean, so many, here he is, works so hard all week long. And Saturday morning, here he is looking great, sitting here in the studio. There's certain doctors just have it, and he's one of them, and I have always applauded him for it. But we're going to talk about something that Dr. Stewart said is very common. I have one, and so why not talk about it? So what is it with these torn menisci, or guess what do we call it if there's more than one?
Yeah, well, you're right. Good morning. The singular is meniscus, and the plural is menisci. And so the menisci are shock absorbers in the knee. There's one on each side. They're C-shaped structures made of cartilage like your nose, and they act as a shock absorber. They are a major part of this major system of the knee. They're very important in the function of the knee. They help distribute fluid in the knee. They work as a shock absorber, and they keep the knee aligned because they are triangular in its cross-section, so it keeps the knee back right where it should be. What happens is they're very vulnerable to rotational injuries. So you can twist your knee. You can do it in bed, getting out of a chair. If you twist just the wrong way, you can tear the meniscus. Now, the meniscus has no blood supply. It has no nerves. So when you tear it, most people don't even know. Half the people I take care of says, oh, yes, I got out of a chair, I felt something pop. But the other half said, I never did anything. All of a sudden, my knee is swollen and painful. It can present as one of different scenarios. Some people present with a very swollen knee. I had a priest that came in the other day, and his knee was swollen, and he couldn't extend it. I mean, he couldn't straighten the knee out because the piece of meniscus had been torn and out of place, and what we call a locked knee. Locked meaning he's unable to straighten it. That's a very painful situation and demands immediate attention. He had an MRI scan, and then he subsequently had surgery to take care of that torn piece of meniscus.
What did you have to do in the surgery?
Well, at his age, we take out the torn piece. Younger people, if we can, we try to repair them. But most menisci cannot be repaired because the meniscus has very little blood supply. So most of them cannot be repaired. We simply take out the torn piece. Now, when I started in the 70s, we would open the knee and take out the whole meniscus. Now, starting in the early 80s, we simply do arthroscopic surgery. That is, with a small microscope through 3/4-inch little holes, go in and look and take out only the torn piece, leaving the majority of the meniscus there, depending upon how much meniscal tissue is torn. That's called arthroscopy or arthroscopic meniscectomy, and that's a very common procedure. Probably more than 1 million are done in this country every year.
When you said that before they would take out the whole meniscus, what would it leave then with the knee?
It would leave no shock absorber. Now, there's a shock absorber on the end of both bones. The femur and the tibia has articular cartilage, different type of cartilage that acts as a shock absorber. And so people did all right initially, but many people 30 years later develop severe arthritis. I see many people now who come to me with that 4-inch incision from the 60s or 70s and now have bad arthritis in their knee and have to have their knee replaced. So the meniscus is a very fragile piece of material. Having said that, you watch these basketball players twist and turn and do all these things, and they rarely have problems. Although Dwayne Wade, as if anyone follows basketball, as you know, has a bad knee. I'm not sure what his pathology is, but it may be a torn meniscus, and he's just sort of putting up with it. When people tear the meniscus, some people have very few symptoms. They have a little ache. Other people come in, as I mentioned, with a locked knee, or some people come in and it says, I only hurt if I do something. Well, we want you to do something. We don't want you to stop being active. As you know, I'm a big proponent of exercise. And my mantra is motion is lotion. People feel better when they exercise.
I have to write that down. Motion is lotion.
Yeah.
I love that. Okay.
So people come in and they say, Doc, I ache all over. And I ask them, well, what do you do for exercise? And they go, well, I really don't. Well, I'm a big fan of 3 parts of exercise. Strength training, meaning resistance training, whether that's weights, machines, or rubber bands. Some type of cardiovascular exercise, walking, riding an exercise bike, swimming, and flexibility or stretching. Those are the 3 main components of exercise. And when a torn meniscus interferes with your ability to do that, then we have to do something. Now, there was a recent study that looked at Medicare-age patients, those over 65, who had a torn meniscus. And they divided the group into two groups. One had the typical arthroscopic surgery. One had physical therapy. The two groups were equal in its success. So not everyone with a torn meniscus needs surgery. Many people have a torn meniscus. It's what they used to call a trick knee. They'd never know when it was going to go out. They'd be fine. All of a sudden, they'd twist and it would hurt for a day or a week. Then they'd get better. Just as they're about to come into the doctor's, their pain goes away. But this becomes a pattern where every 2 or 3 weeks, or sometimes every 2 days, the piece of meniscus will come out of place. I like to use the analogy as like a pebble in your shoe. If you could have a pebble in your shoe that can get to a spot where it doesn't hurt, you're fine. Then it gets to a soft spot where it hurts, and then you've got to sit down, take your shoe off, and take out the pebble. So we likewise will have a time when the piece of meniscus will go back in place, and you'll have no pain. It's not the tear that hurts. It's the meniscal tear that then moves around and becomes caught. That's what causes pain. And that's what can cause the locked knee. Sometimes I can unlock the knee by manipulating the knee and twisting and turning it, and the piece goes back in place. Sometimes nothing short of surgery will do that.
Now, I know when I first came into Dr. Stewart, and I had my knee was swollen, and of course you had, you found out what it was, you knew right away, and then we did have the MRI. But when you took the fluid out, it was much less painful.
Yes.
And you said that it would be, but of course the fluid we know protects something in there. That's why it's there, right?
Well, not really.
Oh.
The fluid in the knee, I like to use the analogy, that's your knee crying.
You have all these. I think you're going to have a book. You're going to write all your analogy. I love it. Just the knee crying.
These are tears from the knee. So just like when you get a speck of dust in your eye tears. When something goes wrong in your knee, whether it's arthritis, gout, infection, or torn meniscus, your knee puts out fluid. Teleologically speaking, it's a way for your body to say to you, slow down, I'm hurting. Don't do what you were doing. So it's a way for your body to stop you from doing the things you were doing. Now, we try to fool Mother Nature by taking the fluid out and giving you a shot of steroid. And that often works dramatically well. And for some people, they have that done a couple times a year, and that's sufficient. Some people, it only works for a week. Some people, it works for 6 months.
Okay, let's go. All right, I'm going to keep stopping you because
Sure.
you have so much good information. Let's talk about the steroid.
Yeah.
What actually does the steroid do?
Yeah. I like to say steroids like putting water on a fire. It really puts out the fire. It reduces the inflammation. We talk about anti-inflammatory medications that we take by mouth, aspirin, Advil, and Aleve, and we can take steroids as well. Steroids are the most effective and the strongest anti-inflammatory. We don't like to use steroids by mouth very often because they do have deleterious side effects in the body. But we do quite often give shots into the joints, whether it's the shoulder, the knee, or whatever. And on a limited basis, they're dramatically helpful. The problem is they have been misused over the years, particularly by athletes. The athlete who on Friday before his game on Saturday would have his knee drained and a shot of steroids so he could perform, the doctor was not doing him a service. That doctor was serving the team, not the patient. And I think there have been many men, and women too for that matter, who have been injured by aggressively treating their knee injuries by steroid injections. Yes, it does help in the short run, but too many shots of steroid are bad for your knee. They can actually help destroy the knee if given in too high a concentration. So we'd like to say 3, maybe 4 shots a year is the maximum.
And that's interesting because I met a man who has had severe back pain, and he's now having a steroid in the back, and he said that he's had his 5th one, and now he has absolutely no pain.
Right. I've had 3 myself. Those are called steroid epidurals, lumbar epidurals, and they can be dramatically helpful for the proper condition.
And so, okay. So that's what you would, and I was talking to Dr. Stewart when he first came in that I've had a foot problem, so I've not been taking care of my knee as I should, but eventually if the pain now that seems to be coming back in my knee doesn't go away, then I guess the next thing's the steroid because we didn't do that. Right.
So we can give you a shot of steroid that can temporarily help. It is a Band-Aid. It is not a cure. If you have a pathology like a torn meniscus, it really depends upon your activity level. If you're a runner if you're a tennis player, if you're very active, you'll probably have to have arthroscopic surgery to cure it. If, however, your exercise is moderate, if you maybe ride a bike and do a little walking, many people can live with it. As I mentioned, half the population over 65 is said to have a torn meniscus. So when I make that diagnosis, that's a pretty good guess because it's very common. But many people, as we get older, are not as active, and consequently, they don't need to have anything done because they're not active enough to have that torn piece irritate their knee.
Now, I know you're a specialist in knee repair and replacement. So when I go up the steps, no problem. When I'm coming down the steps, what is that? My knee's doing something different?
Well, that symptom is the classic symptoms for what we call patellofemoral disease, pain underneath the kneecap. It's the most common knee problem I see. I see it in 10-year-olds. I see it in 12-year-olds. I see it in 60-year-olds. It's pain underneath the kneecap. It doesn't have to be arthritis. It's considered an overload of the joint, and it hurts to squat, hurts to kneel, hurts to go up, but more importantly, downstairs. Excuse me.
Anyway, so, it's interesting because we do have 2 flights of stairs, 20 steps, and that's really what's been a wonderful thing for me because it's a great exercise for me, as I go up and down. But I am noticing, since I have this problem, going downstairs or even going down a level.
Yes.
So it's causing a different action from that knee.
The reason is when your kneecap is part of what we call the extensor mechanism. It is connected to the quadricep muscle. It's a 4 muscle group in the front of your leg. And that kneecap acts as a fulcrum so that muscle can act more effectively biomechanically. And when you're going downstairs, it puts a lot more force underneath the kneecap than going upstairs. It's counterintuitive. You would think there's more force going up because you take more, but the kneecap has a much more higher concentration of pressure going downstairs. So when someone comes to me and they say they hurt more going up, I'm worried that they don't have a true problem. For instance, I take care of workman's compensation injury patients occasionally, and sometimes they're trying to get out of work. And if they tell me it hurts more going up, I question the validity of their claim.
I see. Because going down is the problem.
For most people.
Right.
And that's usually taken care of first by assessing the alignment of the kneecap. Some people's kneecaps don't line up well, often a product of an imbalance in the muscles. And a therapy program can strengthen the muscles to put the kneecap back in the proper alignment. Sometimes it's a product of overuse. You've just planted 250 inpatients. You were down on your knees for 4 hours digging holes. You were just down painting the baseboards of your home. You just visited your daughter. She has a 5th floor walk up in New York, and you had to walk up steps, which you normally don't do. So usually it's a product of some overactivity that you're not used to doing.
Let me just tell everybody this remarkable man who's answering all my questions and probably many of yours that you didn't even know to ask is Dr. Charles Stewart. He's an orthopedic surgeon with the Boca Raton Orthopedic Group in Boca Raton. If you would like more information or you want to make an appointment, his phone number is 561-391-5563. That's 561-391-5563. Well, Dr. Stewart, you, of course, are a specialist in knees. And did you decide that a long time ago? Did it just happen?
Well, interesting. When I first got out, I thought arthroscopic surgery was going to be a flash in the pan because it was new. I did my first one in 1976. We didn't have a camera then. You had to look through an eyepiece. We didn't have the instruments to work. I thought this is going nowhere. Well, was I wrong? So when I moved to Boca Raton in 1984, I joined a man who only did knee arthroscopy. They didn't need any new doctors in town at the time, so I thought, I'll find my niche. I'll just do knees. And that way, the other doctors won't be particularly upset. In our community, people demand specialists. They almost want a right knee specialist and a left knee specialist. It's become that. It's become that specialized. So I decided that I thought I'd be bored, but I'm not. We try to get better with each case, and we try to do a good job. And I thought doing 2 major operations, which is total knees and knee arthroscopy, I would be bored, but I'm not. It's a constant struggle to make it better.
And so have you found people who have both knees that need to be done? I mean, is that common depending on arthritis, I guess, isn't it?
Well, do you mean arthroscopic or total knee replacement?
Both.
Yes. We have people who need both done. In fact, I rarely do both at once, although last week I did a man who was an airline pilot, who said, I can only take 2 weeks off, and I need both knees done. So I did them both. I did them on a Friday, and he came in Monday saying he was doing fine.
Oh, my heavens.
No crutches, no nothing.
Oh, my heavens, that's fantastic.
So he'll be back flying in 10 days. So I don't do it very often unless people are healthy, unless they really say, I have to have both done quickly, mainly because of work restrictions. And the same goes for total knee replacements. Total knee replacement is a big operation, and I used to do a lot of bilateral or both at the same time, but there are higher risk involved. So I do it if the patient is appropriately managed, but I try to talk people out of it, mainly because if you have both done at once, you can't go home. If you do one at a time, you go home in 2 or 3 days. If you have both done at once, you're likely to need a blood transfusion. You rarely need a blood transfusion if you do one. And the risk of death is twice. Now, that risk goes from 1 in 10,000 to 1 in 5,000, so it's not high, but the risk of pulmonary emboli particularly is higher if you do both at once. So I do it. If people say, if both legs are terrible and they're healthy, I'll do it both at once. There's several doctors in town who like doing both at once. I'm not sure why, but I prefer one at a time, but I do them both if necessary.
All right, but then getting back to the knees, but those people, that didn't just happen to them. One day they just, they've been living with it, right?
Interesting you say that. I saw a man the other day who was 66 years old and a professional water skier. He jumps, he does slalom, he does tricks, and he came to me and said he was dragged by a rope, and his first time ever he had knee pain. And we did x-rays. He had terrible arthritis. He had bone-on-bone arthritis. He said it never hurt until this relatively minor injury he had. So there are people who come in whose x-rays show severe arthritis and say they've never had pain until a week ago. So we don't know why some people have x-rays that look bad and they don't really hurt. Other people come in, their x-rays don't look so bad, and they say the pain is terrible. Part of it is people's response to pain. Some people are more sensitive. Part of it's culturally. Some cultures have more sensitivity to pain. And so everybody's a little different in how they approach their pain.
Well, let's just go into that operation. Let's just do the knee operation. Are you literally in there yourself, or are you doing things? Now we have robots and different. How
You're
are
talking
you
about
doing?
knee arthroscopy?
No, I'm actually talking about replacements.
Right. So with knee replacements, it can be done one of 3 ways. The typical way is we do an x-ray ahead of time, and we basically measure about how it should be. And then when we're in the operating room, we use instruments that measure exactly how much bone to take off and instruments we've used for years. Now, the second technology is to use a robot. There are robots being used, not for total knees yet, for half a knee. They're working on that. Although I did work with a man up in Long Island for one day that used a robot that he had developed in the operating room. I found it too cumbersome myself. A third way, which is what I've elected to do, is we do an MRI ahead of time of your knee, your hip, and your ankle. And the company makes me a 3-dimensional model of your knee, and on the computer they make custom specific cutting blocks. Meaning they will actually, on the computer, design how much bone should be taken off and at what angle. And these custom cutting blocks are used in the operating room to guide my cuts. So that's what I prefer. It's more efficient and it's more accurate. And I think that's the way to go. And I've been using that the last 3 years now.
And that's that is, when you think about it, it's almost like it's a model of what that knee really looks like, right? It's almost like when we're having our teeth done, right?
Exactly.
They first go and they see exactly what you need, and then they put those teeth in.
Right. And that's exactly what we do. We make the model, or the company makes the model, and then on the computer, they take your deformity, meaning most people come in, their legs are crooked, bow-legged or knock-kneed, and they will then on the computer decide how much bone should be taken off to correct that malalignment and fit the knee in the proper size. Now, there are custom prostheses. There's one company that does a completely custom prosthesis itself. The company I use has 10 different sizes, so we don't need a custom prosthesis because one of these sizes will almost always fit. But the MRI tells me ahead of time what size fits best.
All right, and we've been talking, of course, generalities. Men and women, are we looking at different recuperation time? Are we looking at better patients, or is that a generalization?
It's dramatically variable. I did a friend of mine a couple of months ago, and she came into a total knee replacement. She came into my office in 2 weeks, driving, and it was a right knee, saying she took one pain pill, and she was ready to fly off to Boston to take care of her grandchildren. So some people do extremely well, male, female. I used to think if you were heavier, you wouldn't do well, but I've had some patients who are very heavy and have done very well. Typically, the heavier patients have less demands, meaning they are not as active as the younger patients. The biggest problem with knee replacements are that people expect sometimes to have a normal knee, and it's not a normal knee. It will never be normal.
What does that mean?
It's metal and plastic. It will never completely be like your index knee was, like a normal knee is. Now, I have some patients who have a knee replacement and say, Doc, I don't even know it's abnormal. I've had both hips replaced. I can't even tell that they're artificial hips. In the knee, that's not the case. Many people who have a knee replacement will say, the bad pain is gone, my leg is straight, but I still feel it click a little bit. There's a little soreness if I'm up too long. So we still aren't at the spot where everyone does perfectly. In fact, I was at a meeting where a man presented a paper reviewing 3 papers from 3 countries, England, Sweden, and U.S. And the percentage of people who were done by very good surgeons who were not happy at 1 year was exactly the same in all 3 papers, 18%. So 18% of people had their knees replaced in 3 different countries were not happy at 1 year. Now, that doesn't mean they were in terrible problems, but the knee wasn't normal. And sometimes it takes a whole year to get as good as you're going to get, and some people are never pleased because one thing or another, it swells a little bit, it aches a little bit. I'm amazed that, truthfully, that we can do these big operations and people can go back to play tennis and snow ski because the knee is a very complex joint. The hip is easy. It's a ball in a socket. There's not many extra motions. The knee is much more complex. There are 3 different degrees of motion in different planes. So to recreate that is difficult. Now, there's a new knee coming out that I'm going to start using next month.
A new knee coming out. I love this. A new heart coming out, a new knee coming out. Okay.
So and all the companies have new knees coming out periodically where they're trying to perfect the normal range of motion. So everybody's striving to get a better knee and have patients have better results. So part of it is the design biomechanically. Part of it is the putting the knee in correctly. But one of the major things that's important is good pain control. Because if you don't have good pain control after surgery, you won't do well. And I think we've ignored that for years. For years we said, this is painful. You'll get through it. Here's some morphine. Tough it out. Now we say, this is painful, but we're going to do everything we can. We have what we call multimodal pain control. That means many ways. And that means that we give you medicines even before the surgery starts. We do a nerve block, so there's very little pain when you're in the hospital. We give you injections into the knee of a long-acting Novocaine. We have a Novocaine now that lasts for 72 hours. And we get you up going very quickly. And so everything is much different than it used to be. When I first started in the 70s, you had to be over 65, coming in a wheelchair, and be ideal body weight. Now my youngest is 32, my heaviest is 300 pounds, and we get people up and going and usually out of the hospital in 2 or 3 days.
And what's your oldest?
94.
94.
So people will criticize, why would you ever do a 94-year-old? Well, he was a retired cardiologist. He said he couldn't travel, that he wanted to do, and he couldn't get around. His daughter was a very aggressive lawyer, said, Dad, you don't need this. And he said, be quiet. So he lived, he lived for 2 more years, and his daughter wrote me a letter and said, I was wrong. My father enjoyed the last 2 years of his life, which he hadn't done the last couple of years before that. So it was a worthwhile thing for him. Now, one of these days, we may have Obamacare may say nobody over 80 will get one. There will be restrictions at some point.
So wrong. No, we can't do that. We can't allow that to happen because
things are going to happen. The problem is we do 600,000 total knees a year in this country. It is estimated we'll be doing 20 million in 20 years. The rise.
Wait, stop. 600,000 now and 20 million in 20 years?
Yes. There's an exponential rise in knees. We used to do equal number of knees and hips. Now we do twice as many knees as hips. And the rise in knee arthritis is dramatic for a variety of reasons. One is obesity. That's our biggest risk factor. Obesity is the biggest risk factor for knee arthritis. The second one is activity level. meaning people who play soccer and football, their knees are often hurt. Not anything dramatic where you ruptured ligaments, but the micro trauma from the cutting and the hitting can lead to early arthritic changes. There are not many pro football players past 50 who haven't had their knees replaced.
What's the third one? You said. Let's see. We had the first thing was
obesity.
Yeah, obesity.
And the next thing is the microtrauma. And the third is genetics. There's some people have genetically poor cartilage.
Yeah,
your mother and father had bad arthritis, and you may have bad arthritis. Just some of us aren't blessed with good cartilage. Just like some of us are blessed with good hair, some have good cartilage. So
you have good hair.
Well, not much of it. But.
It's funny, and we only have a minute or two left, but we ought to really, and I don't know, we don't have time, but there must be some sort of foods that we can be eating. I mean, taking vitamins, taking stuff that we should.
Interesting. That has been a huge deficit in medical education. My son, who graduated from medical school a couple of years ago, had 1 hour of nutrition in his whole program.
Even now, and I thought even now they would be. Okay.
Even now. So there are people who emphasize anti-inflammatory diets. There are certain foods that can be pro-inflammatory. For instance, many people say if they eat a tomato, their joints ache. Tomatoes are acidic.
Yeah, because they're acidic, exactly. Well,
but everybody's different, so there's not an agreement.
Right, I think that would be another good article. You can read Dr. Stewart is actually in our April issue. He's on page 16, but in the Medical Minds. But we have, of course, been lucky enough to have him at our Cure Symposium, and it's always such a pleasure to have you, and thank you so much, Dr. Stewart.
Well, thanks for having me.
Yeah,
Appreciate
bye.
it.